Well, it's certainly got the public attention right now. There is a shortage of donors. There are probably close to 40,000 people waiting for transplantation right now across the country for all different organs. And yet we'll only have about 5,000 available donors this year, which if you're just talking livers would be 5,000 available livers if we could use every liver. Of course, everyone needs, for a different reason, needs to have a liver, and everyone has the different acute needs. Some people need them right away because it's a life and death situation. Some people don't need them right away, but you know that they're in a process of failure. If you look at, as opposed to kidneys, if you look at the liver, where you really don't have a fallback situation, you don't have a dialysis situation, there's nothing that will keep you alive if your liver fails. You start prioritizing how acutely ill a medical patient is, how difficult it is going to be for a patient to survive when their liver is failing. And so we've developed a class system. There are patients that are class 4 that are basically walking around at home, but they're ill. They have liver disease. There are patients that are class 3 that need to come into the hospital quite regularly for care, but can usually be made well enough and stable enough to go home. But they need constant medical attention, and they're getting worse. There are patients that are class 2, and they require being in the hospital. And then there's a priority class, class 1. And those patients usually are in the intensive care unit, and they are patients who are imminently going to die, usually in a matter of days. It sounds like Mickey Mantle came into the hospital in what we'd call or term fulminant failure. He was in, we know that he had alcoholic liver disease and that his liver was failing over a period of time. And a patient like that always has one foot on a medical banana peel. And when they get ill for any number of reasons, and whatever it is can push them over this side of being stable, they can decompensate very, very quickly. And if they do, they can be immediately going from a class 3, which he may have been, or a class 4, to a class 1 in a matter of hours. If they classified him as a class 1 and he had priority, then in fact you would expect that he would go up on the top of the list looking for a transplant. Even though previously he may have been way down, now he's way up at the top of the list because he's going to die very, very shortly. Now he's in competition for a liver, not with class 2, class 3, or class 4 people, but only with other people in that emergent situation. And the first available livers that come along will go to those people. And that must have been what happened in his case. When you're a top priority liver transplant recipient, it doesn't matter if you're Mickey Mantle or John Smith. It matters that you will die imminently without a transplant, and as soon as you come to the list, you go into competition with other people only in that class, which means if there was somebody else before Mickey Mantle for the first liver up, Mickey Mantle would not have gotten the liver. And he would have gotten the next liver that came up. The problem with self-inflicted illnesses, as it's getting to be known, and alcoholism being one of them, is that it is going to, in a certain number of cases, and he's one of them, it's going to result, even if you stop drinking, and he did, in progressive liver disease. That disease is going to continue to get worse. In other words, your liver is going to fail. We know that in patients that have stopped drinking, that have a track record of at least 6 months, actually, but a track record of having reformed, that if they're given a transplant, more than 80% of those patients will never go back to drugs or alcohol, and they'll have a fine life. When you look at justifications, if you look, why should this person have a right to a liver? To keep a patient alive with a failing liver costs tens of thousands of dollars a year, hundreds of thousands of dollars a year, just with medical therapy, not with a transplant, but every year, year in and year out, as they're failing, as their liver is failing. If you do a liver transplant and it costs $150,000 or even $200,000 to perform, and then it only costs $5,000 to $10,000 a year to keep that patient alive and well with medicines thereafter, the liver transplant literally pays society back for having done that, and by not having to continue with medical therapy. The only other option that you have, and our society is not going to adopt that, I don't believe, is to say to a person who has a failing organ on the basis of self-inflicted illness, we're never going to treat you, because at that point we don't have to spend anything for you. There's an overseeing organization, the United Network for Organ Sharing, which the government basically has assigned as a contract to assure the fair allocation of organs. And many of its responsibilities include bringing together numerous professionals, bioethicists, physicians, patients, recipients, all sorts of transplant professionals or people interested in transplantation to formulate or help formulate policy. And it's through those committees, the ethics committee, the organ allocation committee, that those decisions are made. And then locally, hospitals, physicians, and others try and apply those principles to their own patient populations. When it comes to organ allocation, they have the same policy. But when it comes to who they will accept as a potential recipient, those may differ. One center may decide that a particular type of patient with a given set of diseases and a potential outcome is very acceptable for them. Another center may not be willing to take those risks for their patients or for their own program's reputation. It's very difficult to make some of those gray area decisions. But how the organs are distributed, once the center decides that a patient is a recipient, that should be universal. He should not have, no. And when I say that, I'm assuming that the rules were obeyed, and the rules simply are that if he was a class 1, he would have gotten the next available liver up based on when he came to the list. Well, the greatest percentage of deaths will take place for people who are waiting for organs for which there's no backup, and that would be heart and liver. Certainly, even kidney can be a life-saving operation if a patient has lost the ability to undergo dialysis. But the vast majority occur for patients that are waiting for organs that can't be replaced, and that's primarily the heart and the liver. Of course, the heart has actually some assist devices, and that's where the greatest number of deaths take place. Those numbers have come down dramatically as transplant centers have developed the skills to alter organs to different sizes, to split livers and perhaps use them in some cases in 2 different recipients. But there are still people that will die on the list waiting. Actually, not like in the old days. And by the old days, you may remember there were times when past presidents had gone on the air thinking they were doing everyone a favor, asking for a liver for little Timmy or whatever. There are other patients, I think, that came from wealthy families that could afford media coverage or press coverage. And there was a time, certainly in the 70s and early 80s, where that was not uncommon. And it was one of the things that made people try and put a more organized system in place. So will patients still try, or families still try to get some priority? Yes. Is there a way of them doing that? Not if the rules are obeyed, no. And do I think it happens often, or even with on an annual basis? No, I don't. I may have missed that, but certainly there was a rush on everything from the internet to our phones ringing, asking why it was that Mickey Mantle had somehow or another gotten a kidney with a short waiting time. The public was really fixed on the possibility that he had celebrity status and therefore received an organ.